Legislative Task Force on Aging is called to order. We do have a quorum present, combining in person and online. Good morning, everyone, and welcome. We'll start with adopting the previous meeting minutes. Are there any corrections to be added to the previous meeting minutes? All right, do we have a motion to adopt the previous meeting minutes?
So moved, Madam.
Thank you, Chair Cleaborn. Do we have a second? Thank you, Representative Zelesnikar. All in favor of adopting the minutes, say aye.
Aye.
Aye. All opposed, say nay. The meeting minutes for our October 10th meeting are adopted. So we're going to start with a presentation by the Minnesota Association of Geriatrics Inspired Clinicians, or MAGIC. Please come to the testifiers table. Thank you, and if you'd both state your names for the record and proceed with your testimony. Thanks for being here.
Excuse me. So in order to access the PPT, you can only use that. This is just for viewing purposes.
Oh, so I don't have to do anything
Yeah.
with the slides?
Yeah, she'll be doing that. That's the laptop.
Okay.
Good morning, Madam Chair. Thank you for permitting us to contribute to the Task Force on Aging. I'd like to introduce myself, Cathy Lauring. I'm the current president of MAGIC. I'm a geriatric nurse practitioner for 30 years. I'll let Dr. George introduce himself.
I'm George Schoephoerster. I'm a retired geriatrician from St. Cloud.
Our goals for this meeting are to raise awareness for MAGIC's impact on geriatrics care and education in Minnesota, as well as increase our participation in future healthy aging and geriatrics care policy and initiatives.
May I ask you to please pull your microphone just a little bit further, closer? Thank you.
Our purpose is promoting quality geriatrics care and being recognized as a respected leader for our older Minnesotans and those with complex health needs. MAGIC is a state affiliate for the national organizations American Geriatrics Society and the Society of Post-Acute and Long-Term Care. We bring clinical resources, education, and advocacy to improve our care of older Minnesotans. MAGIC's multidisciplinary team utilizes clinical experience, knowledge, and perspective to deliver care consistent with our Minnesota older adults' values and preferences. The older adult and their family is at the heart of the care team and is further surrounded by expertise to support healthy aging. Our leadership team exemplifies the multidisciplinary focus. We have physicians, nurse practitioners, physician assistants, nursing home administrators, and educators. This group comes together from large health systems such as Allina, mHealth Fairview, and smaller systems as Genevieve, LifeSpark, and Twin Cities Physicians. In our community and congregate living arrangements, a strong focus is keeping our older Minnesotans in their residence as long as possible. We do lack providers specializing in geriatrics. This is exacerbated in our rural areas. And as our assisted living communities continue to grow, so does the acuity of the older Minnesotans that reside there. In our nursing home population, there are two primary populations, short stayers and long stayers. Short stayers are focused more on rehabilitation, sometimes terminally ill or on hospice, or medically unstable and unable to return home. Our long stayers, also sometimes called residents, that population is focused primarily on those that have physical, cognitive, or other combination of disabilities and unable to return to a community residence. Looking at a few nursing home statistics, 56% of people aged 57 to 61 will stay in a nursing home at least one night in their lifetime. As you can see, in Minnesota, the number of residents residing in certified nursing homes continues to decline. This started prior to COVID, it continues through, and we still continue to see that decline, which puts a stronger emphasis on community aging and resources. Currently, 2.5% of older Minnesotans live in long-term care communities.
So I'm going to be talking about, the next section is going to be talking about things that are already being worked on and addressed that we call successes, and things I think of as opportunities that we're calling recommendations that we're making to you. And they are in three areas: supporting healthy aging, community connections, ensuring skilled workforce in geriatrics, and innovation in long-term care. So the first success under supporting healthy aging and community connections is we partner in age-friendly ecosystems and multi-sector blueprint for an age-friendly Minnesota work, which were some words that were given to me by somebody who's involved in that, so I'm going to tell you what I think it means. The age-friendly ecosystem is the intersection of the various age-friendly initiatives. The blueprint is a tool that's then used to strategically connect those efforts. I'm going to talk about two of the age-friendly systems. One is age-friendly healthcare, and I'm just going to define it. It'll get talked about further by some of the other people presenting today. I think, excuse me, I think of age-friendly healthcare as care that causes no harms and that is guided by an essential set of evidence-based practices that we call the 4 M's, which are matters, medications, mentation, and mobility. So what matters means that we become aware of and align the care of each older adult's specific healthcare problems as they would like them to be. Medications is, if medications seem to be, looks like they might be helpful, we use age-friendly medications that do not interfere with the other 3 M's. What matters, mentation, and mobility. So first of all, they can't interfere with what the patient wants. They don't interfere with issues around mentation. And what mentation is preventing, identifying, treating, and managing mental health issues like depression, dementia, or delirium successfully and adequately across all settings. And the last one then is mobility, and that is to ensure that older adults can move safely every day to maintain their function, which then allows them to address what matters to them. And it comes to full circle. I also wanted to address Age-Friendly Minnesota that's put together, promoted by AARP. You may have recalled last time when I spoke, I mentioned that I co-chair the effort in St. Cloud. The reason I think it's important is 70%, I mentioned this last time, 70% of those things that improve the quality of life for older adults is non-medical, including such things as social determinants of health. And that's exactly the work that Age-Friendly Minnesota is working on: transportation, mobility, housing, social isolation, and so on. What could be helpful from, I think, from the legislature is more funding to help the grant programs to communities. So there's over 20 communities working on this. We were given an opportunity by AARP to apply for a grant. We came up with a shovel-ready opportunity in St. Cloud for, we thought it would take about $100,000. We got $10,000. And I'm not complaining, we got $10,000, but the issue is there's so many needs. And then Age-Friendly Minnesota is going to engage the citizens, and I think it's going to be an opportunity for it to be effective in making changes.
Excuse me, may I ask a clarifying question?
Sure.
I just want to make sure, you just said that you had received a $10,000 grant from AARP, but were those state funds? Or was
No.
that was AARP
Correct.
funds? Okay, I just wanted to make sure I understood that.
Yeah,
Thank you.
It would be nice if the state could help. And I don't know what it takes to get there, but that was what I was thinking. The second bullet under successes is clinical care delivered to older Minnesotans in their place of residence. And I just wanted, it's becoming very common, and I wanted to give two examples. One example is an organization called Genevieve, who I work for, who is predominantly focused on long-term care. And when I worked, that's where I was, in the nursing home all day, every day. Another organization is Bluestone, and their focus is predominantly in assisted living, but it's the same principle. So our recommendations around this is, it would be nice if there was some way we could increase the opportunity for MDH to be involved in healthy aging initiatives. It wasn't clear in the presentation they made earlier, a couple months ago or whenever it was, that they're doing a lot with that. And it would, if there was some funding available or manpower issues for them, that would be nice. The second issue has to do with care coordination. Care coordination, or excuse me, one part, let's say it that way, one part of the expense and poor outcomes for the elderly lies in not preventing and successfully managing acute crises, which can be caused by dehydration, delirium, or exacerbations of their chronic health problems. So we feel to improve the quality of life and decrease healthcare costs, we have to find a way for all older adults to have access, or at least better access, to care coordination and assistance in navigating the health insurance industry, regardless of who their payer is. So there are some payers who provide that, but many of the older adults do not have it available. The third item has to do with incentivizing geriatric education, and they will be talking about that. I think it's next after I finish. Also, promoting interest in geriatrics among primary care providers. I just wanted to mention, as part of our age-friendly effort in St. Cloud, we did a needs assessment, and one of the few things that was mentioned in St. Cloud amongst those that we talked to was that they had difficulty finding a provider that they thought had any interest or skills in geriatrics. And so that's a huge issue, of having enough clinicians that can do that. Next slide. One way to get more primary care providers interested, I think, in geriatric care would be to bring their knowledge base up to current standards. And so some things that MAGIC is doing to try to help with that is we've standardized guidelines in nursing home standing orders through an ongoing committee that's called MAGIC Alliance for Clinical Excellence, or MAGIC ACE. And so, for instance, this fall, they put together some orders and guidelines for vaccinations, and that's what I used it all for the nursing homes that I'm currently medical director at. A second way they do that is we have an annual conference through MAGIC. It's usually in November, I think. I think it is this year, but I think it's always November. A day and a half where they provide education specifically on geriatric care. And the GWEP, Geriatric Workforce Enhancement Program, again, we'll be talking more about that shortly. So the opportunities, I think, in this section, what we think we would like to see is closer collaboration with clinicians and providers with MDH and DHS as it relates to healthy aging, long-term care and its regulation, and other age-related topics. Our goal would be to get us more involved, sitting at the table, if we can, when those opportunities arise. The other is expanding the medical director role. Just to remind you, the medical director is a consultant to the nursing home, and their responsibility is for assuring the quality of care being provided to the residents in the nursing home and working with the clinical providers to assure that that's happening. There's two things that we would suggest. One is that often nursing homes have medical directors who are barely interested in geriatrics, let alone having any particular insights into providing more modern nursing home care. And to address that, our national organization that was mentioned earlier, AMDA, has a course on that leads to certification in long-term care. It's a week-long course. It's changed over time. I took it many years ago, but it has changed over time. How it's delivered, part of it now is online. The other is, we learned during the pandemic that as we were trying to implement whatever we could come up with as the pandemic occurred and caused such devastation in our nursing homes, we found it hard to get a hold of the medical directors because we didn't know who they were. And so our thought would be if a registry could be developed on medical directors, that would be helpful. And then our last one is innovation in long-term clinical care. With the changing nature of healthcare of older adults, with many of them having more chronic diseases, and with the severity of their illness, and as was mentioned earlier, many of the people in long-term care are part of rehab programs, either post-op or because of strokes or so on. Attempts are underway to try to innovate the way we approach long-term care regardless of the setting. And as the statistics showed earlier, only a small percentage of them actually are in nursing homes. Most of them are in our communities. So one effort for that is ECHO, which is the Extension for Community Healthcare Outcomes. It's a collaborative of interdisciplinary clinical and executive leaders of assisted living facilities and nursing homes who spend about an hour twice a month meeting virtually. And what they're attempting to do is reduce the disparities across the different organizations through sharing best practices and to master the complexity through case-based learning and then monitoring the outcomes of those changes with data. And I think someone's talking about that later. The second innovation was recently put out by the National Academy of Sciences, Engineering, and Medicine, a report that suggested the possibility of the need for transforming nursing home care. They concluded that the way in which the United States finances, delivers, and regulates care in nursing home settings, in their mind, is ineffective, inefficient, fragmented, and unsustainable, and they argue for the need to initiate fundamental change. MAGIC has no position or policy on this. The report's fairly new, but we certainly, as someone who did only long-term care for 15 years, I wouldn't disagree with the conclusion, and if there's any effort to try to address improving how long-term care is done, we certainly would be interested in being part of that process. Our recommendations under this section, we would encourage the more opportunity being taken to leverage the medical directors, particularly ones that are certified, in setting policy and regulations around the state. We'd also like to see more leveraging of the many primary care providers. And we think there's some benefit to continuing to utilize and improve care provided via telemedicine. I think there's a lot of opportunities, but particularly in rural areas, I think there's a real role for that. Next. So that's us. We opened any questions. My email and Cathy's is listed here, though what I would suggest is if you want to connect with us, I would get our executive director, Heidi Holste, who is in the corner over here, and her email is here as well.
Wonderful. Thank you both so much for your testimony. You've sparked a lot of interesting ideas. Are there questions from members of the task force? Chair Claiborne.
Thank you. Mine is just a simple definition of telemedicine. Since we have still some broadband issues across our state, do you believe, I know during COVID, we expanded mental health telemedicine to include audio only. Do you believe that that is a beneficial way for us to do telemedicine in the short term? Or would you think it would be necessary to have that visual contact as well?
I have feelings about that as the author of that bill. But Dr. Schoephoerster.
The answer is complicated. The benefit is getting the insight of the provider with the patient and having it occur across distance because of the benefits that occurs, particularly in rural areas, but sometimes there's some benefit to that even more locally. Traffic in the cities is much worse than it is in rural areas. So what I can tell you is that as an older adult who practiced medicine for a long time, I found taking care of people on a screen, I missed out on a lot of the information that I gather when I'm sitting in the room with somebody. So to me, it was already a step down. When it's just on the phone, I get no information, no body language, no something. Some of my worst mistakes over the last 40 years were taking phone calls in the middle of the night and trying to deal with something over the phone, hardly even being awake sometimes, but certainly not picking up on exactly what was going on with them. So my thought is it's going to be better if we actually have visual, and I think it'll be done better by the younger providers.
Thank you. Follow up? Okay. Other members? Representative Zalesnikar.
Thank you. And thank you for your presentation. I've spent the last 40 years as a nursing home administrator and started as a CNA 40 years ago. So I, like you, have seen a lot of changes and have worked with gerontologists and medical directors in rural Minnesota and greater Minnesota and in Minneapolis, St. Paul's. So my question is, the mandates in healthcare probably are not matched by any other industry. And with that, we have individualized care plans, but that doesn't mean we have one-to-one staffing at a time when we're having extremely high acuity and a staffing workforce issue at the same time. And so would you say, while we've had a lower percentage of seniors, I know what the percentage has been that's typically been in a nursing home for the end of their life, do you see that number expanding with the population of this baby boomers coming through? We have an initiative to have people at home, but do you see a larger percentage of them requiring the nursing home because of sliding scale insulin and unstable medical and the items that you listed? Do you see that number increasing as that overall percentage with the population of the baby boomers?
Ms. Lauring or Dr. Schoephoerster?
So my impression is that the number isn't going to go up because of the interest on the part of the population to prefer to stay at home. That is what I've learned through our age-friendly work, is that that's where people want to stay, at home, whatever they think home is. And I think the pressure, because of the cost of long-term care, it's expensive because these are particularly sick people, but because of that cost, I'm imagining that payers will finally figure out that they need to do a better job of taking care of people in their home rather than long-term care. So I'm imagining that will increase. It'll be supported by technology improvements like telemedicine and things that measure their pulse and blood pressure and so on. I think the people in long-term care are going to continue to become sicker and sicker. So that's already happened. When I started practice in 1982, many of the patients that I took care of in the nursing home, they just lived there. They were fine, they got up and around, they could feed themselves, they left and came back. You know, they'd leave for the day. It was kind of like what we now think of as senior apartments. So it's really evolved already in the last 40 years, and I don't see the number getting bigger. I see the patients getting sicker.
Ms. Lauring, did you want to add anything?
I would agree with Dr. George. I would also add, as we're seeing our assisted living communities growing, we're seeing increased acuity there as well with, you know, insulin and other procedures and technology. I think the increased use of technology, more remote monitoring, as long as people can be able to stay at home, they're going to want to stay there. I think that's where we're going to start to see more community services, and I think that's where if we're going to focus funding, I think it would be better spent there than it would be on nursing homes. I think we'll still have our same people in the nursing home, but we're going to have probably, the practice that I'm in, we serve people in their homes. And I have people that I go out and see in their homes that are as equally as complex as people that I take care of in the nursing home. And I started being a nursing assistant in the late 80s, so fully agree. It's changed a lot over time, but we're seeing a lot more community, and generally that's where people want to stay.
Representative, do you have a follow-up?
Thank you. Yes, I'd just like to ask a couple more questions, because I concur that people want to stay at home. I think my concern is when you can't, and when you require 2, 3, 4 people to lift you, and the obesity is at highest rates we've seen in a long time, along with diabetic conditions, and those two combination is hindering being able to stay at home, and families aren't able to lift a person. And so economies of scale with the workforce is what I'm concerned about for the highest care person, that they will have a quality care as we would probably all define it. And sometimes for those high-level care needs, home may not be possible. And so to use a quality of care standard with initiatives, preserving the ability to have quality skilled nursing facilities across the state are going to be essential. Otherwise, that burden's going to fall on a spouse who's also aging, or they might not have a spouse, and they might not have children in the state to care for them. And so that would be one of my concerns. And then the secondarily is that the reports have said 40% of Minnesotans have increased mental health needs, and clearly the nursing home and the frail elderly took a big part of that. And so would you support making sure that if you are dying or you are in a change of condition, you would always be able to have one person with you? I think people died in isolation, and we've learned that, and staff had to be there for death as the only person. Priests and pastors and families weren't with people. And so that mental health issue from what we all went through as a pandemic is what it is, but as we move forward, would you support making sure there's one person with a person at the end of their life?
I think there was a comment and then a question. Is that right? So would either of you like to take that?
You want to start first?
Dr. Schoephoerster.
So I personally, I hope that people who are getting near the end of life have some support to do that. If they don't have family, I think hospice programs just do an amazing job, at least the ones in the St. Cloud area. And I've never had, so in the nursing homes, so my most recent 10 years have been in the nursing home, not in the office. So in my practice, we had a number of patients in every nursing home that also were involved with hospice, and personally, I never had any trouble having them there, with them being there for the patient during those dying hours.
Thank you both so much for your testimony. It was very insightful, full of a lot of good ideas as we take on this very heavy lift on the task force. If you're able to stay in case there are additional questions after other presentations, that would be wonderful. If you're not, we understand too. Thanks very much.
Thank you for having us.
Next up, we'll hear a presentation by the Minnesota Northstar Geriatrics Workforce Enhancement Program. Please come to the testifiers table.
And how do you, is it in present mode? Yeah, it is, it is. You can see that, you can just click down. Yeah. Just for the slideshow. Sorry.
Okay, yeah, that's fine. Good morning and welcome. Please state your name for the record and proceed with your testimony.
Yes, my name is Kristine Talley. I'm an associate professor from the University of Minnesota School of Nursing.
And I'm Teresa Schicker. I'm the program manager for the Geriatrics Workforce Enhancement Program at the University of Minnesota. Thank you.
Wonderful. Thank you both. Please be sure to get your microphone as close as you can to your mouths when you testify. Go ahead and proceed with your testimony.
Great. Well, thank you for inviting us to let you know about the work that we're doing with our Minnesota Geriatric Workforce Enhancement Program, which we refer to as GWEP. So I'll be using that instead of that big mouthful of a name. You may also hear it as GWEP, but I'm going to call it GWEP. So the Minnesota GWEP is an interprofessional program at the University of Minnesota that is co-directed by the School of Medicine, the School of Nursing, and the School of Public Health. Teresa Schicker is our program manager, and she's the one that helps all of us achieve our goals with this program at the University of Minnesota. Jim Pacala is a geriatrician. He's the lead director. Again, I am Chris Talley. I'm an associate professor in the School of Nursing and also a gerontological nurse practitioner with clinical experience in nursing homes. And then Joe Gaugler is with the School of Public Health, and he is an aging researcher. So as I said, the GWEP is an interprofessional program at the University of Minnesota, and our mission is to bring together Minnesota's best minds in geriatric care and education. We have three broad goals. One of our goals is to transform primary care clinics for age-friendly care and learning. Our second goal is to educate current and future health professionals in age-friendly care. And our third broad goal is to provide dementia care, support, and safety for patients, families, and also direct care workers working with people with dementia. Our program is funded by the federal government, by the Health Resource and Services Administration, otherwise known as HRSA. Currently, HRSA has funded 48 other GWEPs across the nation, and we are the only one in Minnesota with this current funding. We'd like to make you aware of two kind of broad challenges in the geriatric workforce. First, there is a need to increase the number of faculty and health professionals who actually specialize in geriatrics. And this is across all disciplines, in nursing, in medicine, in our long-term care administrators, our allied health professionals such as physical therapists, occupational therapists, speech therapists, and also in dentistry. Our other challenge, while we want to create geriatric specialists, we also need to gerontologize the general healthcare workforce. And so we need to train everyone working in health settings about age-friendly care. And we also need to implement age-friendly practices across the spectrum of health services. So in acute care hospitals, in primary care settings, in dental clinics, and of course, in long-term care. So our GWEP is focused on improving primary care age-friendly practices. And you may know that older Americans account for about 16% of the population of the United States, but they account for 25% of all office visits in primary care settings. I'm also going to mention that they also account for a third of all hospital stays. Remember, this is 16% of our population, and about 2.5% of older people live in nursing homes. What I want to emphasize, across all of these settings, very few health professionals and faculty are specialized in geriatrics. You'll see on here, and as well as we gave you an editorial that you can read that summarizes some of this information as well, but literally less than 1% of health professionals and faculty are specialized in geriatrics or receive training in geriatrics. We're making a little movement with nurse practitioners. About 8% of nurse practitioners now do receive formal training in geriatrics. We've done that at the national level by forcing adult gerontological nurse practitioners to become adult gerontological nurse practitioners. And social workers are actually about 4%. So while we're making some movement in a couple disciplines, it still does not meet the needs of the people who seek care in the United States and in Minnesota. So what needs to be done? We need to incentivize and train faculty and students and health professionals to provide age-friendly care. And we also need to implement and incentivize age-friendly, and we also have dementia-friendly practices in healthcare settings. So at the University of Minnesota, we know how to train and prepare the workforce to prepare age-friendly care. You may ask how the care of older adults is different than for younger adults, particularly in primary care settings. As you probably know, older adults are more likely to have complex health conditions such as multiple medical diagnoses, using multiple medications, having frailty that makes it hard for them to implement their own self-management. And they also experience what we call in geriatrics, geriatric syndromes. And so a geriatric syndrome is something like a fall, or dementia, or delirium, and even urinary incontinence, where it's not just one factor contributing to a problem, it's multiple factors from multiple systems. There may be physiological reasons for the problem, there may be environmental reasons for the problem, there could be some cognitive problems. And the bottom line is that as people get older, they need more complex care management, and they need specialized assessments and management to address the complex needs that they're facing, even in the primary care setting. As I said, only 2.5% of older adults live in long-term care, so most are living in the community with their health conditions. So what are we doing at the GWEP to transform primary care clinics for age-friendly care and learning? With the exception of the Veterans Administration, the GWEP is the only Minnesota organization actually actively working to implement age-friendly care in primary care settings, and we're doing this primarily with mHealth Fairview primary care clinics. And to do this, we have joined a national initiative from the Institute of Healthcare Improvement. And this is a national movement with evidence-based strategies on how to improve age-friendly practices in all settings, in acute care, in primary care, and in long-term care. I'm talking about primary care today. And our previous speaker talked about the 4Ms model, and this model goes across settings. But what this model helps a primary care clinic do is come up with evidence-based ways to assess for mentation issues. So we need to screen for dementia. We need to screen for delirium. We need to screen for depression. We need to screen for mobility issues. And we need to look at the medications that older people are taking and make sure that they're not causing as many problems as they're intended to help. And all of the care plan needs to align with what matters for that older person and their families and the goals and preferences they want for care. So the bottom line is we have the tools and the evidence to help gerontologize primary care, and we're doing it with the 4M framework. So you may ask, what does it look like for a primary care clinic to not be age-friendly? Mm-hmm. And I'll tell you, I asked my colleagues, hey, what has been your experience with an older parent or an older adult in clinics? And the very first person told me, I've got a story for you that I want you to share. And so I've changed names, and these are not pictures of them, but a picture of the scenario. So Margaret was an 80-year-old woman going to see her primary care clinic, and she had actually had the luxury of seeing the same family doc for the last 30 years. So recently, her daughter, who does not live near her, was visiting and decided to join her at her next primary care clinic, mainly because she was noticing that her mom was seeming forgetful and also having trouble walking and was concerned with her driving. So she gets to the clinic. The doctor is addressing her high blood pressure and her diabetes. And he looks at the labs and her assessments, says, these all look good. Those are being managed well. And he turns to Margaret and he says, so how are things going for you? And she says, fine. And he's like, well, that's great. Let's schedule your next appointment. And the daughter, very distraught at this moment, she's like, wait a minute, I have a couple concerns. Like, I'm very concerned about her memory. I'm concerned that she's having trouble walking, she's had some falls, and I'm concerned about her driving. The physician was unprepared for these questions and hurriedly came up with a referral for neurology to check on her memory, which is months out to get. Made a refer for, physical therapy for a walker, but of course, another appointment that they need to get to. And didn't have a solution for the driving at the time of the visit. How could this have looked different if this had been age-friendly practices in primary care? Well, first of all, she would have been asked about memory concerns well before the age of 80. She would have been asked about mobility and falls well before this visit, or at least at an annual visit that she has, or if not with every visit she has with her provider. So when we have age-friendly primary care, we can catch these things early and help get them the supports and the community supports that they need for care, instead of it being incidental to a family member happening to show up on a visit and saying, hey, we have memory problems, walking problems, driving problems. And unfortunately, this is a very common experience for older people in primary care. And so that is what our GWEP right now is working to do with all the mHealth Fairview clinics. So what we have done is we created, I'll go ahead, I'm still on that slide, okay. We created what we call a geriatric smart set. And what this is it's questions and assessments that are built into the electronic health record that screen for memory issues, screen for falls, screen for medications, screens for those 4 M's. And it's built into the care process so that it's asked at every visit so that there's not a surprise that comes up. So there are solutions. We need to get more primary care clinics doing this. To address our second goal of having a shortage of faculty trained in geriatrics and also a shortage of health professionals with geriatric knowledge, we have created and accumulated a lot of resources for people who are training either students or current healthcare workers. So we have created educational resources on age-friendly care. The very first top one is our age-friendly care and education collection. We have harnessed all of the GWEPs across the country, all of the aging professional organizations, and found every educational tool and lecture that they have provided free and made it findable in one repository. This is a highly used repository. We want to get the word out so that if you're not an expert in aging, you can quickly find some resources to get you up to speed on that and to help other health professionals and students learn about that topic quickly. We also have several programs. We're trying to inspire and support the current and future workforce. I'm not going to go through all of these projects. What I want to emphasize is just on this slide alone, we have 9 different projects to address these goals. There is each of these links to those projects, so if anyone wants more information about them, you can quickly get to that. I would also like to highlight, while I'm talking about primary care, one of our projects is with the Minnesota Geriatric Echo in partnership with Hennepin Health that the Magic Group talked about just previously. So we are also working on some long-term care issues as well. The third goal for our GWEP is offering dementia care, support, and safety for families and direct care workers. So we have several programs for health professionals, and these are done in partnership with a lot of Minnesota agencies that are focused on aging. So we have created programs for dementia-friendly dental practices and dementia-friendly work for healthcare offices. So there are tools that we have built with Minnesota partners to help health professionals become age and dementia friendly. We also, though, have programs for families and caregivers, which is critical. One very successful program is led by Joe Gaugler, our Caring for People with Memory Loss, which is an annual conference that goes on, and it is actually for not only healthcare providers, but mostly for family caregivers to come and learn how to support the person that they're caring with that lives with dementia. Joe is also putting on a great, we call it the DEAR program. He is going to every county in Minnesota and talking about dementia education, educational resources and experiences and supports for people with that. We're working with churches to help make them dementia friendly for communities. So again, what I'd like to highlight on here again, we have on this page alone another 8 projects that are working to address this issue. The reach of our Minnesota GWEP has been far and wide. We've had over almost, and we're in year 4 of a 5-year grant, so we're almost hit 39,000 participants. And our participants are not just, students are actually the smallest group of people that we reach. We're also hitting health professionals and staff, but importantly also patients, family, caregivers, and communities. I'd like to call out the importance of our partnership with all of Minnesota's organizations that are interested in advancing age-friendly care and age-friendly communities and age-friendly universities, age-friendly everything is here. So we've had partnerships with over 24 different organizations in Minnesota to implement our programs and reach out. And what I would say to the Minnesota legislature is that it's important to continue to fund these programs that are existing. They are all doing great and important work, and we all partner together very well, and they're very collaborative and easy to work with, and so great work going on there. Teresa, was there anything else you wanted to say about our community partners?
Thank you, Chris, and thank you, Chair and the task force for having us here. I'll just say that as Dr. Talley mentioned, the GWEP has just been around for 4 years, and these partners have been working together collaboratively for decades and really amazing Minnesota organizations here, including public radio and many other resources that are partially funded by the state funds. So thank you for those contributions. And I would also note that as Dr. Talley was talking about the age-friendly health systems and that work inspired by the Institute for Healthcare Improvement, that work that's happening in mHealth Fairview really is upstream, as MDH was talking about last month. So that's offering care that addresses the public health needs sometimes prior to things becoming emergency. So all of these groups working together are truly collaborating for public health.
One thing I would encourage the legislature also to consider are incentives for students, health professionals, and faculty to choose working with older adults. And this is across all disciplines. I'm here advocating for all healthcare disciplines. So the availability of scholarships, stipends while people are in school or training, and loan forgiveness programs for faculty and our health professionals that choose to work in an underserved area. And I would say that working with older adults is an underserved area in Minnesota. So that concludes our presentation on the GWEP. I do want to let you know we are here to partner with Minnesotans to create age-friendly health systems, health professionals, and provide support for people and loved ones living with dementia.
Thank you both very much for your testimony. And thank you for introducing the concept of gerontologizing. I love that. And incentives to increase providers in geriatrics obviously is an important piece of this conversation. Thank goodness for the nurse practitioners and the social workers.
Yeah.
But that certainly is one of our tasks as a state. Thank you so much. Members, are there questions? Representative Zelenskar.
Thank you. I guess I was one of the super minority having a gerontology minor in the 80s.
You are in the less than
So, yeah.
1%.
I didn't realize that.
You are.
My questions are, I have a couple questions for you. On the you mentioned the 9 projects, and I will say I haven't looked at all of your 9 projects in detail, but I'm wondering for the part on the future workforce, have you looked at creating any high school partnerships to bring back health occupation classes like existed in the 80s when I got my CNA so that I could start at 16? I'm wondering if the university, I love that you have the public health, nursing, and medical field. Have you looked at any initiatives with high school partnerships to allow for that CNA coursework?
Dr. Talley.
We have an individual faculty member that has been working with Holste in high schools, but, and actually, it gave me the idea for our next round of the GWEP grant to maybe target lower. I would also say I think it's really important for the state of Minnesota to continue to provide free CNA training.
Yes.
It is a great entryway into healthcare, and to target those high school students, I think, is actually a great incentive.
And thank you, Dr. Talley. If I can add, Representative, that there is a project that the GWEP has been working with for CNA training. It's training for nurses and CNAs and other nursing assistants. And so we have been doing that in collaboration with the International Institute of Minnesota and some other local universities as well, and colleges. So that doesn't directly address trainings high school students, but a wider population.
Thank you, Director Schicker. Follow-up?
Just one. As you can see, this is a passion of mine. My second question is regarding CNAs. When we went through the pandemic, there were many states across the U.S. that waived the CNA registry requirements and had a pathway to bring in care because we were in a crisis. And so we hired people across the United States that were not CNAs. And in Minnesota, I'm not aware we had any negative outcomes. So my question is the university looking at the CNA classwork has changed from 30 hours when I started, and I can tell you I would consider myself a good aide. And it has increased. And so I'm wondering if the University of Minnesota is looking at what level of requirements do we need to have for a pathway into becoming an aide to care for the populations at home and in settings, because right now we're reducing a lot of requirements in multiple areas. And I think we have to be honest and look at, for the care centers and home settings, what are we going to do for opportunities? So that would be my question to
Dr.
your
Talley.
team.
Right now, the GWEP is not working on that issue per se. Like we said, we have provided training to CNAs on certain topics, but that's a good suggestion for us to think about.
Thank you.
Yeah.
And if I may add, Dr. Talley, we have a community advisory board for the Geriatrics Workforce Enhancement Program, and we've been having that conversation quite a bit about the training that's offered for CNAs, what's currently required, whether it's meeting the needs of the population. The conversation is happening more broadly, so there are other partners here who could probably speak to that.
Thank you.
Wonderful. Thank you both very much. I do want to note for, sorry, Ms. Foley.
I know you mentioned that you were looking at increasing faculty to teach for required learning. If you get more people to teach it, is it going to be required for learning? How do you get people to take the courses to do it?
Well, you know,
Dr.
I will
Talley.
tell you, I was very fortunate in my training. I knew in nursing school that I wanted to work with older adults. And I was very fortunate that at the time there was funding for me to go on and become a nurse practitioner in gerontology. And there was also funding that helped me get my PhD because I chose to focus in aging. So those kinds of supports, and those were national initiatives, but I do think that they can be Minnesota initiatives as well. They really can help a person choose to go into aging. If you have a loan forgiveness program, you're not as concerned about, maybe my salary is a little lower working in gerontology, but my training has been covered. And that allows me, gives me financial incentive to do that. So, it's not the only solution, it's one tool in the toolbox, but there are things to incentivize faculty and other health providers to work with older adults that may be on the fence about it and decide to do that.
Thank you. Follow-up? Okay. Chair Claiborne.
Thank you, and I'll just be really brief. So when you started, you talked about working in gerontology and serving individuals living with profound disabilities, right? So I want to make sure that when we are thinking about that 25% of clinic visits, right? It serves a broader population. We know what we're moving to 1.2 million Minnesotans over the age of 65. But we also have a large population of individuals living with disability or complex health issues. So I want to make sure that everything that we are doing is evidence-based. So as we're talking about what does that workforce look like, right? And we're working with community needs. It all has to be evidence-based. And I really appreciate your focus on that. And as we think about what incentives we may need to do as a legislative body, right? We also want that to be evidence-based, so the information that you have to share with us as you go forward in your work would be greatly appreciated. So I just ask that you share that information with us as we go forward. Thank you.
Thank you.
Thank you, and I want to note for people here and viewing online that the links, all of the wonderful information that was just provided is available on the task force website.
Great.
Thank you both so much for your testimony and for your important work.
Well, thank you for having us.
Next up, we have Alzheimer's and Dementia Care presentation by the Alzheimer's Association. Please welcome to the testifiers table. Please state your names for the record and proceed with your testimony.
My name is Niccole Goens. I'm a community health worker for the Culturally Responsive Caregiver Support and Dementia Services with Volunteers of America.
Wonderful, welcome.
And hello, my name is Sam Smith. I'm the State Affairs Director with the Alzheimer's Association, and very proud of how quickly I got my PowerPoint up.
Nice work. Proceed with your testimony when you're ready.
Yeah, and so to briefly describe our agenda today, we are going to be providing some level setting around the state of Alzheimer's here in Minnesota. Looking ahead to our 2023 agenda, we'll be hearing from my friend Niccole, and then looking ahead towards some long-term projects that we think could make a real difference for people living with Alzheimer's or another form of dementia. I guess I spoke too soon about doing a good job with the PowerPoint. Yeah. All right, there we go. So briefly, the Alzheimer's Association is a nonprofit dedicated to ending Alzheimer's and all other forms of dementia by accelerating global research, driving risk reduction and early detection, and maximizing quality care. I'd like to provide a few common terms before we dive in. And so dementia is a general term for a particular group of symptoms, including difficulties with memory, language, and managing skills that are severe enough to interfere with daily life. Alzheimer's disease is an irreversible and progressive brain disorder caused by damage to neurons in the brain. It is the most common cause of dementia, but not the only cause of dementia. And while we at the Alzheimer's Association do have the name Alzheimer's, we focus on and support all forms of dementia. And finally, caregivers are care people who are supporting someone living with dementia by providing unpaid help to spouses, partners, adult children's, kinship networks, or other friends and relatives living with dementia. An important thing to know about caregivers is that they have an extremely important role to play, but not everyone is necessarily going to self-identify as a caregiver, particularly people of color and immigrants who understand their obligation to care for their elders as moral in nature and not necessarily kind of in the medical ways we might be using the term here. So in Minnesota, in 2020, there were 99,000 Minnesotans living with Alzheimer's disease or another form of dementia. We project that number to increase by 21.2% by 2025. As a brief aside, the statistics I'll be using here all come from the Alzheimer's Association Facts and Figures or the Healthy Brain Initiative roadmap that I've shared. And so if you want more details on these, I'm happy to share them. Most people living with Alzheimer's or another dementia have at least one chronic condition, 95%, such as heart disease, diabetes, or stroke. I know in our last meeting, Dr. Gogler characterized Alzheimer's disease as the chronic condition for the elder population. And I think this is partially why, and we can imagine why Alzheimer's disease or another form of dementia makes it much more difficult to manage these chronic conditions and avoid unnecessary acute care, whether that's in an emergency room or hospital visit. Unfortunately, there are serious racial disparities in the rates of Alzheimer's disease. Black Americans are twice as likely as white Americans to develop Alzheimer's disease. Latino Americans are 1.5 times as likely. The statistics are different, but we know that there are elevated rates of Alzheimer's disease in the indigenous community. And I would also add that, when we think about aging issues, I think primarily about rural Minnesota, where we also see significant health disparities. This comes at a cost, both for the caregivers, but also to our medical assistance program. In 2020, Minnesota spent $905 million through public health benefits, caring for or providing long-term support for people living with Alzheimer's or another form of dementia, a number we expect to increase by 2025. But that really is just one part of the picture when it comes to the costs associated with supporting people living with Alzheimer's. In Minnesota alone, 163,000 caregivers provided 225 million hours of unpaid care at a value of $5.3 billion. That was really a staggering number for me when I first joined the association to fully appreciate the invisible, often invisible, but essential work of unpaid caregivers to support a loved one to stay where they want to be, which is most and often at their home. Approximately 1/4 of dementia caregivers are called what we call a sandwich generation caregiver, where they are caring not only for an aging parent, but at least one child. And the pressure and squeeze that comes with that can be extremely challenging. I'm here professionally, but my grandmother died due to complications from Alzheimer's, and so I've seen the stress of being a caregiver firsthand. And the statistics bear this out. nearly 60% of Alzheimer's caregivers rate the emotional stress of caregiving as high or very high. And as many as 40% of caregivers of people with Alzheimer's and other dementias suffer from depression. And obviously, you know, the human impact of caregiving is dramatic, but as policymakers, why does this matter? And I would say the reason is because caregiver burnout is the leading cause for placement in a residential setting like an assisted living or nursing home. And this is, I think there are more wins like this than you'd expect, but this is a case where I think the financial incentives around long-term care, but also where people want to be really align, which is to stay at home. And so the more support we can provide for caregivers, the longer they can keep their family together. And we've spent a lot of time talking about workforce, and I think, you know, primary assertion that I would make is that our long-term services and support system would collapse without the contribution of unpaid caregivers. And so whenever we have conversations about workforce, I think it's essential that we center unpaid caregivers in the role they play. I want to really emphasize, you know, that I come to this work with a lot of optimism, and there are a lot of different reasons for that. But one of them is that we are entering the era of treatment when it comes specifically to Alzheimer's disease. And there are new FDA-approved medications and others in the pipeline that are offering hope for people with Alzheimer's in the dementia community. These medications are not perfect, but they represent real progress towards a future we can imagine where dementia is a condition that is managed and no longer degenerative in nature. And there are two medications, Leqembi and Aduhelm, that treat one of the underlying causes of Alzheimer's. Alzheimer's is a complicated disease, and there are many causes and factors, and so there are other approaches that are happening alongside this and other vectors for Alzheimer's. As these new treatments are, I think the key takeaway as a policymaker is that across the board, these medications are most effective at the earliest stages of the disease. And so it's going to put tremendous pressure on our capacity to diagnose Alzheimer's and other forms of dementia as early as possible so that more people can benefit from these interventions. I would add that there are racial disparities, not just in the prevalence of Alzheimer's, but also in the rates of diagnosis. And so as we look ahead to kind of anticipated challenges, particularly supporting people of color benefiting from these meds, it starts with our efforts to have earlier impactful diagnoses. And while the Alzheimer's Association at the federal level is taking steps to mitigate this, it's important to note that there is a lack of diverse representation in the clinical trials for these medications, and so we are working very hard to improve that. And more on the optimism side of things is that there are a lot of really tremendous community-based organizations supporting people living with Alzheimer's, and that's why my friend Niccole is here. She is a community health worker with Volunteers of America providing culturally responsive caregiver support and dementia services. And so with that, I'll pass it over to Niccole.
Okay. As being a community health worker who I am, a dedicated individual who works tirelessly to improve the lives of others in my community and to promote overall health and well-being. On an average day, I may visit local homes to provide health education, conduct screenings for disease, assist with access to healthcare services, and connect individuals with community resources. Also, we organize and lead community health events, collaborate with other healthcare professionals, and advocate for community health needs. The ultimate goal is to empower our community to make informed decisions about their health and improve overall health outcomes. We also do a virtual platform and educate on brain health, heart health, diabetes, spiritual health, because that always helps the caregivers, and just to be able to support them. We also have a mobile clinic that we use for the health fairs that we do, to be able for them to get memory screens. We do glucose for free and AC1s, because as you know, I'm a little nervous, I'm sorry.
You're doing great.
Diabetes is a major cause for dementia. So myself, as a community health worker, is working towards providing affordable respite care for caregivers and loved ones with dementia. So we have the people that call to try to get some relief, to be able to get out into the community and grocery shop or get their hair done or just have a break for their loved ones and they can't afford to pay for respite care. I have a client that COVID really took over her life. She was the provider for her family. Her husband had a stroke, so he couldn't work. When COVID hit, she was in ICU. She passed away 3 times and they brought her back. She lost her house. Her kids were separated, and her husband ended up in a home for caregiving. So now the state is awarded her husband. He has to live in this place. She was staying with family, and they put her out, and she's in an apartment that she can't maneuver around. She has a 16-year-old daughter that is in high school that cannot be home with her every day to take care of her because she needs it. She walks with a walker. Her vision has changed, and she is very unstable. But because between her and her husband's Medicaid and things combined, they will not pay for PCA services. They will not pay for anything because they say she makes too much money. So, I understand the struggles that caregivers face in caring for their loved ones and the need for breaks and support, and also to be able to keep their loved ones in the home. We really strive for that. In order to make this a reality, the community health worker is actively advocating for a bill to be passed that will provide affordable respite care options for caregivers and helping the caregivers better care for their loved ones. Hard work and determination are driven by a deep sense of compassion and a desire to make a positive impact in the lives of those in their community. By providing this much-needed support, the community health worker, me, is helping caregivers to better care for their loved ones and improve their overall well-being.
Thank you so much for your testimony and for your incredibly important work.
Thank you.
Yeah, thanks, Niccole. You did a great job.
Thank you.
Absolutely. Thank you too, Mr. Smith.
Yeah, and I think Niccole really captured, one of, my core frustrations with the elder care system, where more often than not, we end up waiting to provide care until someone experiences a medical or financial crisis. And that just doesn't make sense. It's expensive. It leads to poor health outcomes. And I just think we can do better here. So the question you all have to face is, where can we make interventions? And so this image, I think, kind of captures the different ways you can support people living with Alzheimer's. The individual people are not meant to represent like a proportion of the population, but just where they kind of fit on the continuum of supports. And it starts with risk reduction. The Lancet Commission found that at least 40% of dementias could be entirely prevented with appropriate kind of public health interventions, changes to diet, et cetera. And so that really is the tip of the spear for our work. However, we are in a phase of treatment and people will get dementia. And so early detection and diagnosis is crucial. Even setting aside the benefits of these treatments as they emerge, there is evidence that an early diagnosis delays placement in a nursing home, has improved outcomes with slower progression of the disease, and empowers people living with this illness to make proactive decisions about the type of care they want. And then finally, we are, of course, very focused on providing safe and quality care for people when home and community-based services or residential treatment is necessary. So where are we focusing in this issue? Our number one priority for the upcoming session is what we're calling a Dementia Services Coordinator. As I said earlier, Minnesota spent $905 million on Alzheimer's disease supports. And there's no one person in state government focusing on Alzheimer's disease. There are tremendous partners in both MDH and DHS, but they're often split between multiple priorities and in the Department of Health kind of bound to satisfying and kind of guiding these federal grant opportunities. And so other states like Wisconsin have seen really tremendous outcomes from a dementia services coordinator to identify service gaps in our continuum, track progress towards our different various state plans on Alzheimer's, and identify additional funding streams that might be available. We support an increase to the Eliminating Health Disparities Initiative grant program, which has created in the early 2000s and is yet to see an increase, and to add Alzheimer's as an eligible use. As I said earlier, a quarter of all caregivers are in the sandwich generation, and with proactive steps, you can reduce your risk of dementia, and so we support creating a voluntary health curriculum for middle school and high school students to learn about brain health and healthy aging, understanding what's happening with grandma or grandpa, and the steps they can take to reduce their risk of dementia. Supporting caregivers is crucial, and Niccole talked about our efforts to fund respite care grants for older adults and people with dementia to increase access, particularly for folks who have significant medical needs, low incomes, but haven't necessarily qualified for medical assistance. The AARP took the lead on legislation to increase funding for the Live Well at Home grant program that we were very happy to support. That is a really effective program, particularly in rural Minnesota, to expand access to home and community-based services like respite and chore without necessarily being on that medical assistance waiver. But, looking to the future, there are a lot of really exciting opportunities that we can take. Making sure I'm still on track with time. And so I think imperative one from our perspective is to simplify the elder care system. And that starts by educating Minnesotans about Alzheimer's disease and the resources and opportunities they have to proactively get support. Ensuring that all settings, and particularly primary care, are equipped with the tools to recognize the signs of dementia and refer their patients for a cognitive assessment as necessary. In a Alzheimer's Fact and Figures report, almost 40% of primary care physicians acknowledged that they were uncomfortable talking about an Alzheimer's diagnosis and were not effectively referring folks who might benefit from it. I think that's a really shocking number. And I know our partners in the geriatric community talked about this, so I'll move along. Raising awareness about available supports is crucial because more often than not, caregivers really only enter the support system when they've had that crisis moment. And then finally, I would urge the Departments of Health and Human Services to focus on efforts to increase alignment between the elderly waiver, alternative care, and older adults service lines through uniform assessment practices and referral forms. Well, these silos, I think, make sense to us as policymakers. They don't really make sense to people who seek help. And it's one continuum for them, and I think the more our systems can reflect that, the more effective they will be, and this can also create better opportunities for data collection as well. Invest in what works, I think, is imperative number 2. We made a big increase in the elderly waiver. I think that was playing catch up, not necessarily getting where we need to be. And invest in the services that work. Again, want to recognize the amazing efforts that VOA-MN is doing and folks like them in the elder space. And so get creative to empower the solutions that are working. And then lastly, I would identify a potential model to consider is what Washington State has done around caregiver support and outreach. They have created a model for folks, again, not yet eligible for Medicaid with those elevated needs, to offer a uniform screening for all caregivers, caregiver-specific service planning. More often than not, our waivered programs really focus on the person who is identified as having a disabling condition, but looping in caregivers has real tremendous benefits. And then based on that assessment and the needs of their care partner, they can leverage a wide array of benefits, including respite, home-delivered meals, minor home repairs, based on a budget that they're essentially given. And this works. This is part of an 1115 waiver, and so they had to demonstrate cost savings, and they saw a decrease in emergency department visits, hospitalization, and even enrollment in home and community-based services. So we empower caregivers, good things happen. And caregivers also really liked the program and reported high levels of satisfaction with the services that they received, and they felt meaningfully involved in the support that they were offered and caring for their loved one. And so to conclude, again, stay hopeful. Minnesota elders make significant contributions to their communities every day. We should be excited about that. These demographic trends are an opportunity, not, something, not a tsunami bearing down upon us, For many people, Minnesota is a great place to age, and there are outstanding organizations serving our elders. And with the right help, at the right time, if it's culturally relevant and available in rural communities, even more people with dementia can live fulfilling lives in the community of their choice. And finally, we know more about Alzheimer's disease and other forms of dementia than ever before, entering an era of treatment. And so we have every reason to be hopeful and optimistic and make smart investments now that will benefit us in the future. And so thank you, everybody, for your time. Happy to answer any questions.
Thank you both very much for your very compelling testimony and for your important work. I see that Ms. Schneider has a question online. We're having trouble hearing. While we work through technical difficulties, does anyone else have a question? Ms. Foley?
What are the leading causes of Alzheimer's and dementia? You mentioned that blacks have a 2 times greater risk, and Native Americans or whatever have 1.5 times. And you mentioned diet is one of the risk preventions, but is that the leading cause of Alzheimer's?
Mr. Smith?
Yeah, Madam Chair, Ms. Foley, I think it's important to note that while there is a genetic correlation between individual families and their risk for Alzheimer's, we're not seeing that when it comes to people of color. And so the primary drivers of, again, I'm not a physician, but would be vascular health, diabetes, and some of these other chronic conditions kind of increasing the risk for developing Alzheimer's. I don't know, Niccole, if you want to add anything.
It could be alcohol, it could be smoking, it could be, the main things are the vascular health and the diabetes. And diabetes is really high in the Black community. So that is one of the major causes of Alzheimer's besides genetic. My grandmother had it, and she wasn't sick, but it was genetic. So that's high.
Thank you. It does seem exciting that there is this opportunity of primary prevention, knowing that as many as 40% of cases could be prevented. Ms. Foley, do you have a follow-up to that question?
I'm good.
Did you have one? Chair Claiborne?
Well, I just heard a dementia presentation last week, and it talks about if we want to do good mental longevity for Alzheimer's and dementia, we need to start in utero, right? So as I think about that, it would be good for us as a committee to maybe receive those guidelines that you talked about so that we can put those on the website as well for people to have. What are those preventative measures? And if we can do those early, right, then we can minimize cost and pain and suffering as well as economic costs. Thank you.
I would make a case for actually pre-conceptual. That's the obstetrician in the room, but yes, Mr. Smith, did you have a comment?
Yeah, there's a lot of, really, I think, helpful and useful information that is available. One thing I was really excited about from last session was we had some legislation to provide some funding to the Department of Health to go out into the community and engage the partners that are supporting, communities of color, understand what dementia is and the meaningful steps they can take to avoid developing a dementia or getting that early diagnosis, and kind of developing some culturally relevant materials. Because I think that's going to be a key part of this is the information exists. We don't need to reinvent the wheel, but it's a question of how can we scale up the information and support we provide so that more Minnesotans can kind of learn about their risk profile and the steps they can take to reduce that risk, or maybe know when it's time to seek a cognitive assessment.
Which is what's so compelling about Chair Claiborne's case, and I love this idea of including it in health curriculum so that young people can start to learn about it, to help take care of themselves and also to understand what's happening in their families and their communities. Representative Zalesnikar, did you say you had a question?
Thank you. And thank you for your presentation. I think when I listen to you, it's obvious and really important that we're all mindful of the importance of physical health. Is our whole comprehensive health is more than just physical.
Yep.
It is mental health and spiritual health, to your point, and emotional health. And so I think for greater Minnesota and suburbs and large metropolitan areas, this idea is very important to have the intervention early. In the socialization needs, we have them when we're young, we have them when we're adults, our age in this room, and we have them when we're seniors. That never ends till the day we die. And so we have to find ways to have transportation. It might look a little different in Ely and in, Proctor and Two Harbors than it does in Burnsville or Red Wing or Minneapolis, St. Paul, but we have to look at creative ways and how to use space in churches that have commercial kitchens so we can do teaching and education and nutrition and have camaraderie for people's socialization needs so that they can thrive in a healthy way. And I think, and then diabetic care and all that, I think right now, to your point, we have an epidemic of diabetic need and conditions. And so having a healthy weight for us to have a healthy brain and a healthy mind and to feel good and learning that role we can play in our 20s and 30s to take care of our physical health and what does that look like, and our mental health and our social health and our intellectual health. So I appreciate your feedback today and look forward to innovative ways we can circle back for comprehensive health at earlier times. So thank you.
Can I say something? I just want to piggyback off of what you said. We have a platform called Ask a Nurse, and we have a registered nurse that comes in, and we make breakfast for the seniors that come in, healthy breakfast, and she teaches and educates on how to eat, what mental health is, just a variety of different things. Sometimes we are able to provide rides with a van, to bring people in. I think that with the younger Black community, the health disparities, not being able to get education on older adults aging or what dementia is, not being able to go to the doctor for transportation, not able to get health care. We have that health disparity in our community, and us, where we work, it's 6 of us, Black women, and not just helping the aging adults, we also try to help the other younger adults get the things that they need or try to educate them on dementia and Alzheimer's. We do the walk every year, we're just trying to make a difference for older adults and their loved ones, because the young ones are going to have to take care of us. My children, I would hope they will be able to take care of me without going into a nursing home, but being able to take care of me and have the funding and things they need to be able to take care of me if they need be, so.
Thank you. Those are really important points.
Yes, thank you.
We're going to give Ms. Schneider another chance to ask her question. Okay, I think we'll have to go offline with that question.
And we do
Chair
have
Cleveland.
one comment from the public, just to make sure that we mention the fact that traumatic brain injury, head injury are also causes for Alzheimer's. And so making sure that we do whatever we can to fight falls, as was mentioned earlier as well. Thank you.
Yeah, absolutely. I meant to add that, so thank you, member of the public.
Thank you both so much for your testimony and for your important work for being here today. Really grateful.
Thank you.
Thank you for your time.
Thank you. Next, we'll have end-of-life planning and care presentation. Welcome to the testifiers table. Please state your name for the record and proceed with your testimony.
Suzanne Scheller of Scheller Legal Solutions, and let me pull up this information. I will say that there's many more slides in the packet that I won't be focusing on here today, but I'm an educator, so I put in a lot of education, and you never know what might help somebody. So at this point in time, let me put this on a full screen, I think. Sorry. I'm going to need, you're good up there, but I'm not good here. I'm not seeing what you're seeing up there. So if someone can come up and help me, I'll just continue while maybe Andrew does that. So I have a very different lens with my work, and this has been wonderful to hear all the presenters, and I'm so thrilled for this task force, because essentially, when you're taught, when I'm getting the conversation at the back end. I have people calling me after the diagnosis, after the placement in a long-term care facility, asking about how do I avoid guardianship, asking about different end-of-life planning considerations. Thank you. And so my lens is that reaction and response, typically. Through that, however, I recognize the great importance of good policy, of good systems. And this is what I would say in general. When I talk to people, they are contacting me because they have just entered a system that they do not know how to navigate. And so that is one thing that I would just urge everyone to consider, that until you live it, you don't necessarily understand it. I talked to a group of 20 seniors, and the topic was elder abuse and neglect, and they were on the door of potential need for long-term care placement and services, and I could tell by their eyes that they were glazed over and not really engaging because they're desperately trying to avoid something. So I think our conversation really needs to talk about ageism and value, because until we value and put proper value on our older Americans, our older Minnesotans, we won't have people wanting to enter the long-term care world. So I really think we need to broadly think about ageism. Is there anything here that might already be playing into discrimination or prejudice of older individuals, and that all we do encourages the value that the individuals have? So that's an overall lens that, as I've been listening, it's very important. And I will just say that when I'm talking about end-of-life care and planning to people, they are actually thinking of financial arrangements, funeral arrangements, estate planning, powers of attorney, healthcare directives, and healthcare arrangements. And so there's a whole gamut in end-of-life planning of what they're thinking through. And a lot of it, actually, they're trying to avoid the health outcomes, but they're focused on some of these other outcomes. My talk today is going to be looking at those health outcomes. So healthcare arrangements at end of life, oftentimes we're talking about a person appointing an agent, a person stating their wishes for what they want. The person may complete what I call a medical-related document, a Holste or a DNR, DNI. They may seek legal means to end life, medical aid in dying. And at times, we have engaged, I have walked through clients with medical ethics board review of what do we do with the individual. So the one thing that I wanted to say is when it comes to end-of-life decisions, we are grounded constitutionally in the consent of the individual. So when we're talking about those decisions, what we've really been trying historically to get at is what would they have wanted had they been able to tell us. Medical ethics boards, for instance, typically work on clear and convincing evidence of what that is. There's some definition of terms that I'm not going to go over here. But there's two types of this end-of-life planning. One is a just in case. You're coming in to do a will. You think, okay, how do we, my kids are telling me we need to get things in order. And so you are then creating a healthcare directive or a power of attorney just in case it's needed. It's not imminent, but we may need it. Or they're coming in because they're at that point of need. And those are two very different conversations and two very different outcomes and thought processes. So, but what I want to analogize this whole end-of-life planning with is oftentimes the appointment of an agent or the writing of your wishes is like a password. And how many of us have been sitting at a computer and saying, what was that password? I don't remember it. I can't get in. I am blocked. And I am experiencing a lot of individuals who have not done a healthcare directive or have not appointed the agent. Your spouse is legally not able to make healthcare decisions for you. That shocks people. And they are locked out. They're locked out. And that's not a good outcome for older individuals, to not have their support system, to be able to interact with them and help them through those decisions. So one thing I did want to highlight is this idea of incapacity and competency when you're making end-of-life decisions. So unless we start with a lens. In my elder law classes, I say there's three main things about elder law. Who is the client? Is it the daughter or son who's coming to me, or is it the older individual who's coming to me? I would advocate it's the older individual. Does the client have capacity? Can they legally draft and sign the documents that we're asking them to sign or they want to sign? And three, all roads lead to medical assistance. So we need to be thinking how our estate plans and our systems account for that elderly waiver, the medical assistance piece. Because as we've heard, the one thing that could actually drive more people into nursing homes is the idea that elderly waiver is not something they can take advantage of, even because they can't even pay the housing part of the assisted living. Assisted living elderly waiver only pays for the services, it doesn't pay for the housing. So for individuals that I'm working with who don't have funds to even pay the housing, even on a GRH, a group residential housing, a lower rate, they're forced. They're forced into a nursing home, which doesn't distinguish between housing and services, and it's going to, the medical assistance is going to pay for both housing and services. So I do have a concern, and that was our concern in the 80s when we put a moratorium on nursing home builds, is we thought they don't necessarily need, the person who's going out in the community during the day, they don't necessarily need skilled nursing level of care. So we want to encourage them to be in their homes or in assisted livings at this point in time. But I see some recycling back to that concept when our models and our medical assistance is not accounting for those less restrictive environments, if you will, in some cases. Similarly, in home care, which is absolutely necessary, our elderly waiver for those age 65 plus has in general, actually a straight MA, straight and medical assistance, in general I've seen clients get about a max of 10 hours of PCA care with a home care model where they need benefits for that care. And as most of us would know, that eliminates quite a few people because they really need the 24/7 monitoring, and they're not able to get that. So I think if we've encouraged people to stay home, we think they should stay home, then we need to create our medical assistance or our benefits pictures to account for that for our low-income individuals. So I'm getting ahead of myself a little bit on the competency discussion, but the thing I wanted to say about the ability to, in essence, our law says you are capable of making whatever decisions you want to make unless you are determined by a court to not have that competency, such as guardianship, or some other lack of decision-making capacity as defined in statute. I'm going to go forward here. There's a provider perspective and framework to this, and ultimately one of my suggestions is going to be more conversation between providers and other professionals serving the aging, like attorneys. Because, for instance, the provider perspective is related to all of the very wonderful evidence-based research that they have and the care that they're giving. But for instance, I am encountering several times where the provider is making a determination about someone's legal capacity to draft a document, where our healthcare directive statute 145C says that the person would lack medical decision-making capacity. So I've had providers tell me they're not capable of signing that legal document. And while I know legal capacity is not, it's a little gray, right? It's a little subjective. I continually have this tension between providers who say, you can't sign that document, you can't draft that document from a medical decision-making capacity. Whereas I'm saying, I believe they have legal capacity to sign that document because we're trying to avoid guardianship and do a least restrictive alternative. So I would like greater conversation between the provider and attorney community and other professionals that are serving our older population, which may help both sides in all of those conversations. The other thing I wanted to mention is in my world, the healthcare directive is a legal document. It appoints an agent or says your wishes. It is not a POST, a physician's order for life-sustaining treatment. It is not a DNR, DNI. So many times, education for the family members around, if you have that heart event with a healthcare directive that says, please don't give me CPR if I have a cardiac arrest, the ambulance is still going to come and give you CPR because that is not a doctor's order related to the healthcare directive. So then we get into the DNR, DNI, and POST, which are physician's orders. So my conversation is usually how
Excuse me, Ms. Scheller.
strongly do you feel about something? Yeah.
Could I ask you, when you were using DNR, DIR, if you could just briefly state what they are so the people
Sure.
in the public who may not know
Sure.
would have a fuller understanding? Thank you.
Absolutely. I'll go to this slide, which is a little bit more of a graphic. Do not resuscitate, DNR. Do not intubate, a breathing tube, DNI. And that document has often been used historically in the long-term care context. So not necessarily a terminal diagnosis, but rather we are in some type of long-term care scenario. And it may be that doctor's order. It may, when I say EMTALA, that's the emergency medical treatment. I'm about to stop there, sorry. The rest of the acronym is on one of these slides. But it's the Federal Emergency Medical Treatment Act. And so that is DNR, DNI is a common document in the long-term care setting, a nursing home, and assisted living. The POST, the Physician's Order for Life-Sustaining Treatment, was actually originally created related to terminal diagnosis and what would be your wishes at end of life. It's more expansive than do not resuscitate, do not intubate. It has antibiotics, it has therapies, it has some other information on that about what you would want to happen or not in a terminally ill context, and it is a doctor's order. And so that is the only document, in my opinion, besides perhaps the DNR, DNI, that would prevent that emergency CPR if you did not want that, because it essentially says we don't have that duty to stabilize anymore legally. And so now we will look at your wishes related to no intervention there, no emergency intervention. The healthcare directive, again, is appointing the agent, stating your wishes. And then there's usually a HIPAA designation, a Health Insurance Portability and Accountability Act designation about the agent being able to get your medical information. So that's an important piece of the healthcare directive. I did want to cover just briefly that there would be the possibility of some clauses in your healthcare directive that I think we need to have more education around. If a person has Alzheimer's or dementia, we may have some end-of-life choices clauses in those healthcare directives. And many don't know about those possibilities. So they can be for mental health advanced directives. We've had a COVID clause in some of our healthcare directives that was essentially use the respirator on someone else. Aid in dying clauses, someone who wants to voluntarily stop eating and drinking, and they know that already. There might be that language in the healthcare directive. So I wanted to, there's a few examples on your slides of what those clauses may mean in those documents. Again, to get at particular diagnoses and situations, and language around dementia clauses often, for instance, say, here is how I define quality of life. And if my status is below that quality, then I want ABC to happen. So they're really looking at defining what they believe, the patient believes is quality of life, and what they want to happen at that time. I'm going to move forward on the concepts of medical aid in dying, which I was asked to speak about. The development of right-to-die concepts nationally started, many starting places, but the Patient Self-Determination Act was one piece of federal legislation that really brought to the forefront the idea of physicians proactively asking their patients, do you have a healthcare directive? Would you like to sign a healthcare directive? Patient self-determination. Let us know what you want so we can do that. The right to refuse treatment, a lot of our dying concepts are couched, as I said, in this informed consent idea of you have the right to refuse treatment if you don't wish to have that treatment. I won't go over the Patient Self-Determination Act, but there is broad powers under that right to refuse treatment. You may refuse to eat, you may refuse to drink, you may refuse to prolong life, and you do have a right to terminate life-sustaining treatment once begun. Medical aid in dying is considered an active method of dying. It is legal in 11 jurisdictions and considered patient-directed with physician assistance. The patient is making the decision. Death with Dignity Act in Oregon is one of the front runners of that. That is legal under, again, the patient making that decision, the physician generally just prescribing a lethal medication, but the patient self-administers that. So there's a separation of the physician's involvement in prescribing a medication that could end the person's life, and then the person being able to administer it themselves. All forms of euthanasia are illegal, so this is not what we're talking about. There are, however, I want to make sure people are aware, there's active methods, the prescription to hasten death. There's non-active methods, terminal sedation, voluntarily stopping eating and drinking, that is akin to voluntarily refusing food or fluid, and then stopping life-sustaining medication or treatment. I have had clients come to me and say, Alzheimer's has been prevalent in my loved ones, in my family. I don't want to continue if I get to that level. And so they have asked me to write in a voluntarily stopping eating and drinking clause to make sure that people understand at the time it might be utilized, that was the wish when a person was of sound mind, and to alleviate the very real concerns of a husband following your wishes or a family member following your wishes, that is difficult. So they wanted to put in writing those things beforehand. These are the jurisdictions that have the active medical aid in dying, the active method. Oregon has been around the longest, since 1994. So we in Minnesota do not have active medical aid in dying. We have passive methods available that we talked about, and they're grounded again in that right to refuse life-sustaining treatment. Wasn't asked to mention this, but I did want to highlight, we do have medical futility concepts that I do think need to be looked at. In the area of aging, some states have medical futility statutes, meaning the provider believes that further treatment would be medically futile, but the healthcare agent or the family member or the person themselves wants to continue that treatment. So there's a tension there. In Minnesota, the provider does have a right to refuse care under some very specific regulations and procedures. So, all right. So I think in general with end-of-life planning, what's working is the medical providers seeking healthcare directives. There's various forms that are easily found that a person can do that. I'm going to go right to the possible changes because it incorporates the challenges as well. Currently, our statute reads that a person would act and make medical decisions when the principal, the patient, lacks medical decision-making capacity. I find that troubling for some clients and they do, because unfortunately, we may not have a primary care physician. We may not have someone who understands our history. And then we may be asking someone who really doesn't know us very well to make a decision of whether or not you have medical decision-making capacity to trigger the authority of the agent. So I more often am drafting a healthcare directive stating it's effective upon signing it with a trusted agent. So we have that conversation. Do you want this delayed? Because you're never released of your own ability to make those decisions. It's just that you're appointing someone to concurrently make them. So that is, I don't know that we're at a place to change 145C, but all of our forms are ones that are readily accessible to people, have this language of, if I am unable to make a decision, then this person can act. And unfortunately then, I have had providers say, well, they're their own person. That's their language. They're their own person. And so then the agent is blocked out when they really would have wanted the agent to have a voice in the conversation. But providers legitimately are trying in good faith to make that determination. So I would like to see more conversation and forms around, do you want to appoint them now? The possible changes are this idea of terminal condition versus non-terminal and what we should be looking at. This is a huge issue, increasing the number of third-party healthcare agents. I routinely, weekly, am getting solo seniors who do not have anyone. They may even have family, but they don't want to appoint the family members. And that is stopping them. I say, well, at least we can say your wishes. But so solo seniors is a big one. I'm going to highlight, because I know we're over time, the main ones that I have here. I already highlighted the more conversations between the attorneys and providers, and increasing the number of third-party agents. And I will highlight hospice transparency. It is a wonderful program. However, I am routinely hearing of those in the long-term care arena who have had bad outcomes as a result of hospice. I think we need to change our hospice Bill of Rights in some ways, because they are not given the full information of what that program means, whether or not they can go off hospice to get treatment. Had people during COVID go on hospice, you'll get more care, you'll get more medication, you'll get pain medication. Well, for one thing, they should have access to pain medication regardless of being on hospice. When I see the get more care, because of staff shortages, it too often can be a slippery slope to the regular providers exiting, assuming the hospice provider is going to do something. And so patients have died when they were otherwise not at the point of death. And they were told this will be helpful. And all of a sudden the mindset of hospice then came into play, that this person has already acknowledged that they're going to die and ready to die, and then they're dead. So I get very concerned about that from a consumer and a patient perspective, that they're told all of the information, and also that it's not utilized in a way that it was not intended to be. So this goes to one of my other main points of feedback about siloed care, that in the long-term care arena, we have the nursing home who comes in and brings a wound care person, or provider coming in, who has maybe even home care coming in to do something else. So the siloed care, hospice is in that range of silos. I get very concerned about the gaps between those silos. So that would be the coordination in the long-term care arena is a main concern that I have. I don't know how many clients I have had wound care that has advanced when the nurse practitioner, the physician, all doing wonderful jobs, but wound care was taking care of wound care and no one else looked at the wound. The provider wouldn't let the family see the wound because that would be a HIPAA violation. And the nurse practitioner and the physician were assuming the wound care qualified person was doing that. And so I get very concerned about wound care and the silo of that, where no one's necessarily checking in on that, and it develops and advances and causes sepsis and death. So that particular silo is coming back again and again. I will pause because I know I know I'm over time, but there's so many things from a practical perspective when I see it coming at me that I'm happy to provide any other comments after you read and want more. So
Thank you very much. We could spend an entire morning listening to you and learning from you. We don't have much time, but are there questions from members? Anyone online? Okay. Chair Cleavorn is wondering if you'd be willing to come back and speak with us more on another day.
Absolutely, absolutely. This is a wonderful area.
Thank
and-
you.
And passionate about it, so yeah.
Thank you very much for sharing your expertise. And with that, I think we have some public testimony. Cathy Laval is signed up to testify. Welcome to the testifiers table. Please state your name for the record and proceed with your testimony.
My name is Cathy Laval. Thank you all for the opportunity to speak to you about elder care. My mom, Audrey Reed Laval, was a victim of Alzheimer's, along with her father, my grandfather, along with 5 of his 6 siblings. I cared for my mom at our family home, and when it came time to place her, my 4 siblings found a place that they liked. When I toured and asked the staff member how she or her staff would handle behavior that I dealt with routinely, her answer was a shrug. On the day that she moved in, there were no nurses on duty for the first week. I had to be present in order to administer her meds twice a day. It took them a week to get them ordered by the MD and along with the meds ordered into the facility. During her stay, there were over 100 times of medication errors, partially due to the poorly educated, non-licensed staff. At one point, she had had a Schedule II narcotic in her system, given to her that was not ordered by her physicians. She endured multiple UTIs, a broken hip, and following returning back to the facility after the broken hip, within 4 days, she fell in the dining room and ended up with 2 types of brain bleeds, which resulted in her death. Her death certificate was signed by the Dakota County coroner. Following her death, the legislation passed bills which included programs on Alzheimer's and required that the facilities used it for training. Better licensing of the multi-million-dollar assisted living and memory care facilities also came, allowing families to place hidden cameras in their loved ones' rooms. This one helped save a friend's sister who had dementia and was nonverbal while living in an assisted living in Burnsville. Her sister was brutally raped. It was caught on video and allowed Burnsville Police Department and the Dakota County Attorney to charge the caregiver. If that camera had not been there, who knows how long she would have been terrorized along with possibly other residents in the building. So thank you so very much for passing this legislation. As for family caregivers, they need our support, education, along with the healthcare providers with our changing community and family dynamics. Some ideas are the ability to go to support groups, being able to express their frustration and get new ideas or tricks on how to care for their loved ones. One case in point that I helped, a 5-foot wife was having problems bathing her 6-foot 6-inch husband. At the support group she attended, which I ran, I told her to try contacting her husband's physician, to tell them if they could come up with help. At the next meeting, she came in so excited because they were able to get staff to come out to help her husband with her bathing, and she became his wife again. When family caregivers place their loved ones in a facility, they then are still caregivers, but they can become the caregiver advocate for their loved one. When things go wrong in facilities, family caregivers can and have had post-traumatic stress disorders. From the story I told above, to a family member who was assured that their loved one would be checked on daily each day while they were on their vacation out of the country, only to have their loved one die and not be noticed until 5 days later after his death. Thank you again for your time and your efforts to provide care for our multi-billion-dollar priced senior citizens. They deserve it. Are there any questions that I can answer or try to answer for you?
Thank you very much for sharing your story and your family's story. Members, are there questions?
I just want you to know that we hear you. And the messages that you've brought forward and the stories that you brought forward are very important to the work that we're doing. So thank you for sharing those deeply personal stories.
Thank you.
Thank you very much for your testimony. I believe there was one other person who signed up to testify today, and I don't have their name. Anyone? Okay. When's our next meeting? Okay. All right, thanks everyone who came today and who are watching online. With that, we are adjourned.